Okay, hi, good morning everyone. This is Dr. Heidi Wald. I'm probably known to many of you who have been on these calls. I'm a kind of a content matter advisor for CHA with regard to this project. I'm a geriatrician, primarily appointed at University of Colorado, and have a long-standing interest in UTI. And one of the pieces of feedback that we've gotten is a concern about, withholding antibiotics and doing watchful waiting in patients who might have a positive UA or a suspected, an unexplained symptom that might be consistent with a UTI, and concern of really liability if we miss something. And I think it's a really important concern. And so CHA did a little bit of investigation. We were able to work with a law student to look at the case law that we thought might be relevant to this area and to share with you. So a different angle from what we've done on past webinars. And I'm just going to advance this.
Oh, you might have to click on it.
Can you help me? Oh, there you go. I got it. Okay, so disclosures. I have funding from AHRQ, Agency for Healthcare Research and Quality, the Copic Foundation, and consult to CHA. Teri, who you'll hear from in a bit, has
no disclosures.
Okay, so these are the objectives for today's webinar: to identify the choosing wisely recommendations for antibiotic use, and actually specifically as it pertains to urinary tract infection. We are then, after a little bit of background, going to analyze malpractice actions for negligent antimicrobial overuse as something that doesn't get talked about as much as some other topics. And then give some recommendations for strategies to manage risk when choosing to withhold antibiotics. So, and we'll kind of frame it with a case. This is a case I have used once or twice before, so I hope you haven't seen it already. But this is a case of an 87-year-old long-term care resident who had a history of stroke and depression. And she presents to the emergency department with falls and confusion and no localizing symptoms, and that includes nothing localizing to the urinary tract. And in the emergency department, she has urine studies sent despite the absence of localizing symptoms, looking for an explanation for her change in behavior. And it shows trace leukocyte esterase positive and some bacteria, but not kind of overwhelmingly positive for UTI. And she had a CT of the head that was negative for acute bleed. So she did get antibiotics, and she was admitted to medicine. So I'm going to use this case to talk a little bit about what we consider in stewardship a significant problem, which is overprescribing for urinary tract infection. This is a study from Infection Control and Hospital Epidemiology in 2009, and they just did really descriptive study. They looked at over 400 general medicine inpatients at an academic medical center. And if you look at the pie chart on the side, so 46% of them had no antibiotics during their hospitalization, but the rest, which is more than 50%, had antibiotics, and the largest group of them had antibiotics specifically for urinary tract infections. So either we're having kind of rampant epidemic of urinary tract infections requiring hospitalization, or we're maybe overdiagnosing UTI. It turns out of these patients, 60% had gotten their antibiotics started in the ED. Of the UTIs. More than half of them had gotten the antibiotics in the ED. Ultimately, 40% of those UTIs had no organism identified, so they actually didn't have an infection. A third never met any type of symptom criteria for a UTI. And one of the positives is that the vast majority of them did have appropriate narrowing of antibiotics once these things were identified. The conclusion from this study was that despite the lack of benefit, antibiotic treatment of asymptomatic bacteria is actually quite common, and gets to one of the points that we've highlighted in this collaborative, that the UA UA in particular is not a great test. There's a lot of reasons for a positive UA, particularly in a frail older population, and that it is probably overused. The other point to make from another study from kind of the older, the geriatric population, is that when we do choose antibiotics, our choices of antibiotics are probably commonly inappropriate because our older patients have significant amounts of resistance to fluoroquinolones and trimethoprim sulfa, older patients and nursing patients in particular. And so those are not first-line monotherapy, and of course we see that a lot. And this is just highlighted in the data from the Colorado Hospital Association. So this is baseline Q3 of last year data, and I believe the last box, the blue box, is actually Q4 of last year. So we have the baseline, the retrospective data, then Q3 and Q4 of 2015, the different color bars. And you can see that we still have below 50% of cases of UTI actually meeting any definitions of UTI, again, with regard to symptomatology or culture results, and that we still have over 40% of our cases being primarily treated with a fluoroquinolone, despite the fact that, for empiric therapy, that is not first-line therapy because of resistance. So we have evidence, although slightly improving, that we're no better than kind of this other data would have suggested in the state of Colorado. And of course, just to drive home the point that antibiotic overuse for UTI is going to contribute to antimicrobial resistance in nursing homes in particular, and in hospital settings. And at the level of the individual patient, in addition to whatever other adverse drug reactions, the real increasing epidemic of Clostridium difficile, again, particularly devastating in an elderly population. So I just wanted to review the choosing wisely recommendations that I could find that were related to urinary tract infection, diagnosis, and treatment. This is from the American Urogynecologic Society. They specifically address the use of a fluoroquinolone antibiotic as a first-line therapy for uncomplicated UTI in women, and they recommend its avoidance. And so, again, it's just specifically around antibiotic use. The second choosing wisely recommendation that I found was the AGX, American Geriatric Society. Don't use antimicrobials to treat bacteriuria in older adults unless specific urinary tract symptoms are present. So they go further than empiric choice, and they talk specifically about diagnosis. I'm sorry, don't treat at all unless you have localizing symptoms. And then the third one that I found was don't obtain urine cultures unless there are clear signs and symptoms that localize to the urinary tract. So AMDA, the American Medical Directors Association, this is kind of the nursing home docs association, they actually go a step further and say don't even send that urine culture unless you can really localize to the urinary tract. And this, these recommendations get to really what the drivers of overuse of antibiotics are. So I listed the ones that I think are most common. One is medical knowledge, that I think a lot of providers are not aware that asymptomatic bacteria, ASB, is a benign condition that doesn't require treatment. You don't have to sterilize the urinary tract if it's not causing difficulty, and it's increasingly common as patients age. The cognitive errors, I think, in a lot of settings, you're excited to find something positive so that you can create a plan, for the patient and move them through the system because of the time pressures that we face. And so I think we can be very excited when we find a positive UA, hoping that that explains what's going on. There is the cultural bias, right? That people feel that antibiotics are, they are inexpensive, relatively speaking, and they feel that it's low risk to use them. And we hope that this stewardship initiative points out that there are significant risks, both at the population and the individual level. And then finally, and the one we're focused on today, that missing sepsis, is going to be a lawsuit. I'm going to get sued, or it's going to be a problem for me. Whereas just throwing, a fluoroquinolone at a patient is not that. And so, real pressures around the medical legal environment. And so, this led to, again, the interest we had in over-prescribing and what were the medical legal risks. Before we dive into specific actions around antibiotic use, I did want to, this is from a recent survey published in this Medscape Malpractice report just last December. So it is true that most docs, and this is self-reported from physicians who got sued, why they got sued. And I wanted to point out that two important ones relevant here are failure to diagnose, 31%. Of suits were failure to diagnose, and failure to treat were 12%. And I think that those two together are important drivers for physicians. And I do think, though, that it cuts both ways, and I think the cases that we're going to highlight will show you that. This is just to highlight that the malpractice environment does influence how providers approach patient care. Unfortunately. This question I thought was fascinating. They actually did ask, does choosing wisely, the whole campaign from the ACP Foundation, lead to more lawsuits? And more respondents felt yes than no. What I didn't understand is why they felt it led to more lawsuits. Did they think that there was a standard of care that providers weren't living up to? Or did they feel like that choosing wisely was telling you to underprescribe or undertreat or underdiagnose, and therefore they were open to more suits? So I'll leave that out there as an open question. I don't know what they were thinking and when providers answered this question. Okay, and now I'm going to turn over to Teri Hulett to tell you about the cases.
Okay, thank you guys. So we had a handful of cases that our law student reviewed, looking specifically at outcomes with cases specific to what we were interested in. What we ended up with were 7 lawsuits. 2 of them were administrative actions, and the common theme as we went through case by case was misdiagnosis, which goes back to what Heidi shared in the self-reported survey that was done. So failed to make a diagnosis. And what we'll do is go through a few of these cases real quickly and just kind of explain how they fell out. Failed to make a diagnosis. Hall versus Frankel. It was a post-operative total knee patient. The surgeon called for concern about surgical scar, so there was a perception that this patient might have had a surgical site infection, but did not know about the patient's hypoxemia, so the physician didn't have all of the pieces of information. The patient was prescribed antibiotics, and the pulmonary embolism was missed. So prescribing antibiotics without first examining the patient or reviewing the chart can be considered substandard care, and this physician did not go see the patient before he made a diagnosis. So poor outcome. Okay, this one was an administrative action, OSTAD versus New York State Department of Health. And this patient had repeatedly prescribed antibiotics for this physician had repeatedly prescribed antibiotics for 4 pediatric patients complaining of a sore throat, red throat, without adequate medical histories, and he didn't see the patients. This one was pretty significant because he was making diagnosis and prescribing antibiotics that were ineffective, and he actually lost his license. On to the next one. Turner versus Montefiore Medical Center. This was a misdiagnosis of an infection that led to inappropriately administered antibiotics. This patient developed C. diff and ended up dying. And the literature, the case law that was pulled up, it was actually documented that the physician should test and not guess. So making sure that you know what you're treating for and that the antibiotics you're prescribing are actually appropriate and effective. So this one was a failure to recognize C. diff after antibiotics case. Holman versus Nyack Hospital. And this patient was diagnosed with pneumonia and placed on antibiotics. And pretty quickly the patient developed GI symptoms and diarrhea. This physician failed to recognize C. diff after placing the patient on the antibiotic for pneumonia. I'm sorry, we kind of missed, I forgot to fill this one in. But I believe this patient passed away. And it went on for quite a while, and it was not identified that the patient had C. diff until the very end. So this was an administrative action. Again, failure to diagnose, and again, failure to recognize the C. diff. Peter versus the Inspector General. And this was felt to be gross neglect, if I remember correctly through our reading. The patient had GI symptoms, elevated white count, was treated for sepsis. This patient was actually given Imodium, and they did not pick up on her C. diff till the very end as well. And so the outcome was prescribing antibiotics as a shotgun therapy without knowing the source of the infection was malpractice.
Well, this is administrative action.
We didn't put it in there. Okay. So this was another physician that was excluded from practicing in the state for a year, and specifically with Medicare patients. Another misdiagnosis, Babiak versus Goldberg. This was a 40-year-old female diagnosed with a urinary tract infection, and this goes back to some of what we talked about earlier in terms of this patient had no UTI symptoms, nothing definitive, and actually had negative urine testing, but the patient was still placed on antibiotics, and the antibiotics were continued despite the absence of any resolution of her signs and symptoms. She later was diagnosed with advanced bladder cancer requiring systemic chemo. And she was awarded a $3 million finding for gross damages. So that one was pretty significant. This was another misdiagnosis, Ramkisson versus McIntosh, a 54-year-old patient with hematuria and flu-like symptoms following a contrast CT scan. And kind of a little history with her is she had this history of autoimmune hemolytic anemia, and she felt like her urine symptoms were specific to her autoimmune disease. They still diagnosed her with a UTI, treated her with antibiotics, and missed the whole real issue. She was awarded $9.5 million for a wrongful death because her death was tied strictly to the fact that her diagnosis was missed. Esposito versus Choida. This was another misdiagnosis. A pediatric patient with severe testicular pain. Parents took him into his primary care provider, who diagnosed him with the UTI and treated him with antibiotics. Didn't test him for testicular torsion, didn't follow up any further, sent this patient home, and he ended up having to have one of his testicles removed. He was awarded $400,000 for pain and suffering. So the themes that we came up with, most cases involved physicians who prescribed antibiotics without making the proper diagnosis or without looking at the patients and truly assessing what their risk was and if they fit the criteria for a urinary tract infection. Several UTIs were diagnosed in error, and I think specifically of concern were the ones that were treated despite the negative testing that was done. Several cases involved not just adjusting antibiotics, prescribed after the patient showed no signs of improvement. So again, really following the patients and being aware of what's going on. Strategies to manage risk. This one goes back to your empiric therapy. Not treating just in case. It does not absolve you from responsibility should something bad turn up down the road in terms of your outcomes. Documenting your diagnostic reasoning. Why, number one, why are you ordering the tests? Are there really symptoms specific to the urinary tract? and then documenting rationale for your antibiotics instead of just covering in case. And then the other big thing is being aware of patients who are on antibiotics and the C. diff risk, and testing those patients for C. diff should they develop diarrhea during the course or shortly after their antibiotic therapy. Strategies to manage risk with your UTIs. When considering a UTI, if you have negative test results, you don't have a UTI. And if you do have positive results, but you have an asymptomatic patient, you still don't have a UTI. If the clinical scenario is not consistent with your urinary tract infection, you need to look at other diagnoses and broaden your differential to make sure you're not missing something. Appropriate empiric therapy for UTI means knowing your local resistance patterns and understanding the clinical context that goes into your patients and your UTIs, and not just covering to say you've done something. So the case resolution with our patient, during the evaluation, she had a delirium assessment test done with the confusion assessment module and had an MRI. Her neurology consult was done. PTOT eval was called in, and what they found is she had a visual field defect. Her MRI was consistent with a right PCA territory stroke. So no UTI symptoms, no reason for her to have been treated, and a good diagnosis was made. And that's it for us. And we'll open the line for questions.
If you guys have any background noise, please be sure to either mute your line, or you can press *6 if you don't have a mute button on your phone. But the lines are now open for question and answer and open discussion. Does anyone have a question for Heidi and Teri? We've got about 7 minutes before we end the call.
Well, I can just make some comments while people are gathering thoughts. You know, we found this very interesting. You know, we were curious, particularly in the era where, you know, most patients don't die from antibiotic therapy, you know, that's willy-nilly treated. But, you know, I see regularly in my geriatric practice patients who are really suffering with C. diff. And, you know, a lot of that, you know, my concern is a lot of that is, oh, every time we have a, you know, we check a UA, it's positive, and so we're trying to sterilize the bladder. And so we were curious, you know, is there case law out there? And certainly, you know, we found kind of two strains. You know, I'll just highlight. The one is we called something UTI and we just missed what was really happening. In the case of the case presentation of the woman that Teri and I told you about, you know, she didn't have any major ill effect from having gotten the ceftriaxone to treat the UTI. So ultimately, you know, there was not a bad outcome for her, but she was exposed to ceftriaxone unnecessarily. You know, the other strain of case, then there were two other strains of cases, again, just to summarize. The, gosh, you gave antibiotics and then you weren't attuned to the fact that there was C. diff in treating it. So, and I think in this day and age, right, you know, that's, you know, that's not standard of care, right? Somebody develops an acute diarrheal illness, and you need to ask about previous antibiotics. There's a lot of community-acquired C. diff, a lot, and I'm sure you've all seen that. And then the other strain of cases are ones that weren't necessarily on point with regard to UTI, but were just on point with regard to prescribing antibiotics without understanding what the diagnosis is can leave you open. We didn't present all the cases. There was one that was, you know, a community-acquired cellulitis that became aggressive very quickly, that was never broadened to cover for MRSA, and the patient then ended up super ill, septic, with lots of broad spectrum antibiotics, leading to C. diff, which contributed to her demise. So ultimately, so we kind of found three buckets of cases that we thought were relevant to this topic.
And I think the other piece that we touched on very briefly, but in addition to the misdiagnosis, the overtreatment with antibiotics, and the risk for C. diff, is the antimicrobial resistance. And the more those patients are exposed to antibiotics unnecessarily, the more we drive the potential for increasing resistance.
And I'll make one more comment before we... Oh, did someone have a question? There's an open line that's making a little bit of static.
Okay, we're good now.
Oh, yeah. One of the other interesting things I think is that, when something like this happens in a frail older patient, like a nursing home type patient, in a state like Colorado, there might not be a malpractice action because, it's going to be harder to prove what the damages are when a 95-year-old with dementia, dies related to C. diff. However, so I don't think that this case law reflects the experience of patients across the spectrum, in particular the frail elderly.
We've got about 3 minutes for questions. If anyone on the line has a question, please shout it out. I'll check the chat box to see if anyone, you can also type in the chat box. Nope.
Hi, this is Lori from Memorial. Will this presentation, the PowerPoint, be available to share with physician groups and things like that?
Absolutely.
Sure.
Yep.
Okay, thank you. Will you just send it out?
Yeah, it'll be posted on the box.com site, and we're also exploring options to make a podcast. We haven't quite gotten there yet, but we're exploring our options.
Oh, okay. All right, great. Thank you.
Yeah, you're welcome.
It says attendees on hold.
Any other questions before we close the line? Got about 2 minutes left. Are you guys getting ready? Okay. All right. Well, if you guys think of any questions, or if your providers have any questions, feel free to shoot them along. I think everyone knows our email addresses by this point. And we will definitely make this recording available so you can share with other providers and make sure that we get this information out there. So I hope you guys all have a wonderful Thursday. Have a great day.
Thank you.